Hello there. I'd like to speak now about renal vascular disorders. Much of this is material that you've encountered before here in our school in Block 4 when we talked cardiology and the circulatory system. This hypertensive nephropathy, you know exactly what it is. It's going to be hyaline arteriolosclerosis, that's arteriolar damage. It's going to be that unless you have malignant hypertension, which is an episode of very dramatic hypertension, in which case you're going to have a hyperplastic arteriolosclerosis. And so the hyaline arterial sclerosis is going to be just chronic, kind of subpresentational, subsymptomatic hypertension. And then once you start seeing symptoms, you're going to get hyperplastic arteriolosclerosis, which has this onion skinning appearance to it. You've seen that before. Renovascular hypertension. This section's really talking in reference to atherosclerosis and the renal artery, the big boy right there going into the kidney, not arteriolo. You know, we're not talking about small blood vessels in this section. We're talking about the renal artery. And so there are two disease processes brought up in this SDL that you already know about. The first one's atherosclerosis, and the second one is fibromuscular dysplasia. And so atherosclerosis, what does that cause? Stenosis around the trunk of the renal artery that branches right off of the aorta at around the L1 level, L2. And then fibromuscular dysplasia is beads on a string, little focal stenoses due to defects in either the intima or the media or the adventitia. It's typically the media of a vessel, but it can be the intima or the adventitia. And so medial dysplasia means the tunica media swells and grows concentrically inwards and compresses at a little slice of an artery. And when that happens at multiple points, you get this beads on a string appearance like you see in the right picture in this double panel here. And then on the left, what are we looking at? A focal renal artery stenosis right next to the aorta. And so you're saying this patient's got atherosclerosis. So atherosclerosis is a disease of the elderly. Fibromuscular dysplasia favors middle-aged women. That's it. You know it. You know it already. And either of these, when you get them, what's going to happen to the kidney? Let's draw on a kidney. What's going to happen to the kidney that's downstream of that stenosis, or the kidney that's downstream of this stenosis here? You know, it's going to see a lower GFR because there's less blood perfusing that kidney. And in response to that low GFR, it pops out renin. And that renin goes to angiotensin II and aldosterone and works to vasoconstrict and conserve sodium and raise blood volume. So you know exactly what's happened here. Easy SDL. Easy, easy, easy. Up until this point. Okay, now it's a real SDL. So we start talking about other renal vascular diseases. Atheroembolic renal disease, well, the name gives it away. It's an embolus of fat, atheroembolic. So you have a fatty plaque, it ruptures and breaks off. And remember, this is how you get MIs, you know? This is how you get coronary syndrome, cardiac arrest. You have a fatty plaque, a grade 5 or grade 6 plaque, and the cap of it, the fibrous cap, breaks off and spins downstream a little bit. And when it finds an artery so small that it can't go any farther, it occludes it, and everything else downstream gets ischemic, hypoperfused, and then you start to see tissue necrosis as that ischemia compiles. And so in this case, it's the kidney that's getting occluded, and it's cholesterol that's doing the occluding, and you've got to go find that clot. Otherwise, it's going to develop into a wedge-shaped infarct right here. That's exactly what it's going to look like. And look at that pale yellow pallor in this infarcted area. Where have you seen that before? You've seen that in the heart. That's exactly what an MI looks like. That's coagulative necrosis downstream from an obstruction. So we completely understand atheroembolic renal disease. And if you were to slice open a blood vessel where this is occurring, you're going to see histology that essentially looks like a vasculitis, but confined to one area of the kidney. So you'll see angiitis, which is inflammation of the walls of a small, medium, or large blood vessel. You'll see neutrophils and eosinophils, an acute inflammatory reaction. And you might also see giant cells, as you might see in something like a Takayasu arteritis, or that giant cell arteritis, temporal arteritis. Remember, you can see giant cells in that too. That's a medium arteritis. So you know what the histology looks like too. And you could see a couple characteristic presenting symptoms. Blue toe syndrome, number one, because it's atherosclerotic in origin. So these patients probably have a lot of peripheral arterial occlusion because of fatty plaques. And then livedo reticularis as well. You can get a medium vessel vasculitis after you occlude a medium vessel, and then the entire stretch of artery downstream from the occlusion is going to swell up eventually, and then neutrophils and eosinophils get up inside it, and it looks just like a vasculitis, except it's going to be in one little area, not systemic. So that livedo reticularis is going to be just a linear red or purple tracing along the distribution of a medium artery. Then we've got sickle cell nephropathy. Sickle cell will really damage the kidneys because sickle cell disease is almost synonymous with microvascular clots all over the body. And you see clots because of these sickle cells. They're improperly formed red blood cells. Well, specifically, they've got an improper hemoglobin. And that hemoglobin is going to have a glutamine to valine single nucleotide polymorphism in the beta globin subunit of that hemoglobin. And remember, hemoglobin is 2 alphas and 2 betas. And so if you have this one mutation in your beta globin, then hemoglobin is going to want to stick together and clump together and aggregate. And so when that happens, then the red blood cell is going to lose its shape as that globin becomes less soluble and aggregates. And then you see the sickle cell morphology. And so a bunch of sickle cells can clump together and start to occlude small blood vessels. And when that happens in the kidney, you see microinfarctions generating downstream ischemic injury. And when you get a microinfarction of an arteriole in the kidney, well, what's going to happen is that everything downstream from that infarction in about 30 minutes to an hour is going to be dead. And then so the rest of the kidney that's healthy and not infarcted will have to undergo compensatory hypertrophy in order to maintain the glomerular filtration rate. And so that is going to be very bad in the long term. You're going to see presenting symptoms of hematuria. Why? Because there's this clot that's composed largely of red blood cells in the kidney. And so the other red blood cells are going to get pushed through the remaining basement membranes that are progressively damaged by the escalating GFR. You're also going to see a diminished concentrating capacity of the kidneys. That's reflected in lab values as a low specific gravity. Remember, specific gravity is the density of urine compared to water. And so the higher the specific gravity, you can kind of correlate to the higher the osmolarity or the solute concentration of that urine. And the lower it is, the closer the osmolarity and thus the solute concentration and thus the density of that urine compared to water. So that's the easy test that's going to tell you this patient's got really, really bad off kidney function because concentrating is dependent upon a functional tubular epithelium, which is going to be knocked off in the case of a wedge-shaped infarction. You got it. Now we're going to talk about diffuse cortical necrosis. It's diffuse because it's in both kidneys. It's cortical because the cortex of the kidneys, if you look, where's the pallor? What's pale? The cortices. So everything outside that green outline that I just made, that's the cortex of the kidney. That's what just died in both kidneys here. It's pale, it's infarcted. So it's not necessarily infarcted, it's just ischemic, period. And that's what the ischemic cell death looks like, is that pale kidney. And it's pale because it's being hypoperfused. And if you were to clamp down on the renal artery going into the kidney, if you were to put a big old clamp on that thing, the first part of the kidney that would die would be the cortex, because that's the farthest away from the artery. You think the medulla is going to die first? No, it's right next to the artery. It's got an anterior to posterior. That's where all the big branches are. That's going to be the last thing that dies, like how the outside of the heart is the last thing that dies because it's closest to where the coronary arteries penetrate into the wall of the heart. Same principle here. You can treat the cortex as being analogous to the subendocardial layer that dies first in myocardial infarction. So you see this happening. You typically see it. You don't really see it because this patient's going to go downhill so fast that if you don't get them on dialysis, then they're probably going to die because their kidneys will absolutely shut down. That's what it says here in this SDL, sudden anuria leading to uremic death, meaning they die because nitrogen gets so high in their bloodstream that their body can't get it out. And so if they want you to pick this as the correct answer in an exam, they're going to tell you probably the patient died due to sudden anuria, and here's what their kidneys look like. And both of them are affected. And so you'll say, okay, something was happening to cause hypoperfusion of both kidneys bilaterally, leading to ischemia. So what could do that? Great question. If they want to ask you that, common answers are going to be eclampsia, extreme hypertension, which could create a bilateral renal artery stenosis, or which could mess with your hemostasis. Something like septic shock, which could cause a widespread inflammation of your vasculature and get you headed into disseminated intravascular coagulation. Hemolytic uremic syndrome could do the same thing by depleting your platelets and tying up blood elsewhere in the circulation. Extensive surgery just leading to straight up hypovolemia, blood loss, that could do it as well. So anything that's going to drop perfusion to your kidneys is going to cause this bilateral cortical infarction, which manifests grossly as pallor. So what's DIC? Disseminated intravascular coagulation is dysregulated hemostasis. And when we say hemostasis, there's the clotting part of that and the anti-clotting part of that. And so whenever the balance tips too far towards the clotting side, let's say the clotting side would get heavier, right? So when you're clotting too much, disseminated intravascular coagulation. Does that make sense? You know, all over the place in your bloodstream, you've got clots. That's what the disease is. So how does that happen? Well, it happens because of this protein called tissue factor. And tissue factor, I've drawn out here. I know it's like reversed on the mirror, but picture tissue factor being on the inside of your blood vessels. But normally you have a layer of endothelial cells that are covering up that tissue factor. So here's our endothelium. And you don't see the tissue factor anymore because there's a layer of endothelium normally covering this tissue factor. But when there's endothelial damage, those cells get ripped off and the tissue factor gets exposed. So then what happens? Well, tissue factor activates the clotting cascade. It's going to bind platelets. It's going to bind and activate factor 7. So if you have a lot of endothelial damage all over your body because of a systemic inflammation like sepsis, MODS, you know, big time cytokines that are agitating endothelial cells to the point where they slough off, or maybe it's a trauma, a blunt trauma, a burn, something like that. You've got widespread endothelial damage. What that means is that you've got widespread tissue factor exposure. And so you're going to have widespread clotting because factor 7 is going to jump all over that tissue factor. Platelets are going to jump all over that tissue factor. So that's how you get the thrombocytopenia that you see in disseminated intravascular coagulation. And you clot all over the place. And so when that happens, that means that there's a lot of different areas of ischemia. There's a lot of different processes of ischemia taking place at the same time. And some of those clots could be in the renal arteries, you know, and if they happen in the renal arteries, well, again, the cortex is the first thing that's going to get hypoperfused and ischemic. So you see DIC, you remember tissue factor. How's the tissue factor get exposed? Endothelial damage. How do you get the endothelial damage? Acute sepsis, acute, what's it called? When your own immune system, you know, just starts producing all those cytokine storm, something like that. That could give you this DIC. So a thrombotic microangiopathy, what's that? Well, that means that you've got a lot of clots, it's thrombotic, and then it's a problem in very small blood vessels, microangiopathy. And the reason why we want to learn about this is because it can lead to a microangiopathic hemolytic anemia. And that can go downstream really, really quickly because as soon as you start getting anemic, Well, not only are you getting anemic, you're rapidly getting anemic. And so when you get anemic, what's that mean? It means your oxygen carrying capacity is just going down, 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 and your O2 sat is going down, 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 because you don't have any hemoglobin to pick up that oxygen when a red blood cell rolls around to the lungs, because there are less red blood cells total. So you need to correct this. And how you would correct it? Well, it would typically be by anticoagulants, because this is a clotting problem. And the more clots that you have, how do these red blood cells break? How do you get the anemia? The red blood cell is just a beach ball, and it's floating around, and then it hits a clot. And here's a good graphic at the bottom of page 11. Red blood cell hits a clot, and man, that thing just breaks. And no more red blood cell after it smacks into that clot. It's like getting hit with a dump truck or a bulldozer, you know, or a tank. So that's the general mechanism of a microangiopathic hemolytic anemia. And you want to get a Coombs test to see if this is an autoimmune hemolytic anemia whenever you do get the lab readout that says that the patient's hemoglobin or red count has dropped 20% in the past 4 hours, you know. So you get that Coombs test, it comes back negative. What that means is that you drop some antigens in a vial of patient's red blood cells and they don't aggregate. And so what that means is it's not an autoimmunity. So it's not a type 2 hypersensitivity. So you know that it's probably microangiopathic. You know that it's probably due to clots busting open red blood cells. That's what you're going to infer after that Coombs test comes back negative. So the microangiopathy leading into the anemia is a final common pathway of many different clinical syndromes. We say final because you either control this or the patient's not got a lot of time left. So what's the characterization? Microthrombi, typically in small arteries and capillaries. Where do you have a lot of small arteries and capillaries? The kidneys and the brain. So that's where these diseases affect first because of the multitude of capillary beds, kidneys and brain. And what do you see in the kidneys? Focally ischemic or congested glomerular tufts. Because the glomerulus is the capillary bed. It's the smallest blood vessel in the kidney, period. So if there's any clot going into the kidney, it's going to occlude at some point before the glomerulus. Because if it just makes it through all the way through the glomerulus, it wasn't even a clot to begin with, you know. So how do you get the clots that burst the blood vessels? Well, two real ways that we talk about in this SDL. The first one is TTP, and the second one is HUS. So let's break those down one at a time. TTP stands for Thrombotic Thrombocytopenic Purpura. So thrombotic, what's that mean? You're clotting all over the place. Thrombocytopenic, because you're clotting all over the place, you're pulling platelets into the clots. And so your total blood platelets goes down because you're using them all. Yeah. Purpura, what's that mean? Whenever you have platelet-induced clots all over your body, especially in the skin, it'll present as little bumpy red dot rashes, because when you get this clot, there will be endothelial damage, and so there will be vasodilation with the inflammatory cytokines that accompany that. And so red blood cells, especially red blood cells that pop open because of this microangiopathic hemolytic anemia, will spill into interstitial tissue where they get stuck. And then the heme in that tissue has a pigment to it. That's why your blood's red. And so when red blood cells get stuck in the interstitium of the skin because they leaked out of skin capillaries, you get little red dots all over your arm. Hope that makes sense. TTP, what causes it? A deficiency of ADAMTS13, that's how I'm going to pronounce it, which is a protease that cleaves von Willebrand factor. And von Willebrand factor is a procoagulant that helps you clot. It stabilizes and activates factor VIII. And it also binds to collagen and activates platelets. So it can activate clotting in two different ways. Now, if you don't have this ADAMTS13 degrading von Willebrand factor, what that means is you've got too much von Willebrand factor. So you clot everywhere, all over the place, because of all the von Willebrand factor. Anytime you've got some endothelial damage, von Willebrand factor can bind to that tissue factor here. Yeah, so When the endothelium is disrupted, von Willebrand factor immediately binds to collagen that's underneath the endothelium. Clot all over, the clots rupture red blood cells. Microangiopathic hemolytic anemia. That's about what's going on here, you know? And that's a little bit different from hemolytic uremic syndrome. I'm gonna tell you how. Thrombotic thrombocytopenic purpura, well, the purpura in there means there's a skin manifestation. So you're gonna see a rash all over the place. And really, with TTP, it's a systemic disease. No part of your body is left untouched by this disease, potentially. Versus HUS that likes to preferentially affect the kidneys. Now, it's gonna do the exact same thing. You get a lot of clots, and the clots get big, and red blood cells hit the clots and pop open. Same exact pathology, but it's more localized to the kidneys in HUS. Now, there's something else that's different about HUS too. You get it in kids, young kids, and they get it after they have an upset stomach. And the upset stomach is typically Shigella or E. coli or Strep pneumo, one of those big three. And so the bacteria hits their stomach, but it persists and it gets into their kidneys. And the toxin that these bacteria produce gets into their kidneys. And this Shigella-like toxin is going to bind to endothelial cells of the glomerulus. And it's going to get immune cells to intravasate into the glomerulus and pop off and blow up and cause inflammation, leading to clotting because of the endothelial damage. So HUS is a symptomatic triad of anemia, low red blood cell count, or maybe a low hematocrit, or maybe, I don't know, how else would you see anemia? And then you're going to see acute renal failure. That's symptom number 2. So what's that manifest as? High BUN, high serum creatinine, kidneys aren't working. Maybe low specific gravity if they start failing to concentrate. And then thrombocytopenia, low platelet count. So you remember those 3 symptoms. You remember you see it in kids after an infection that's got Shigella toxin or a Shigella-like toxin. It's pretty easy then. You've got this antecedent bloody diarrhea in 70% of cases. The majority of cases, the chief complaint, they go into the ER and the kid's got bloody diarrhea. And you see that and you're thinking infectious etiology 8 or 9 times out of 10, you know. And one more time, HUS is pretty particular to the kidneys because of this Shigella-like toxin that likes to preferentially damage glomerular endothelial cells versus TTP that is an ADAMTS13 deficiency leading to overactivation of von Willebrand factor that doesn't have any particular tissue tropism. It will clot wherever there's endothelial damage. So 2 syndromes, same mechanism, different results. Finally, we've got adult hemolytic uremic syndrome, which is the same triad of anemia, acute renal failure, thrombocytopenia, except they're not going to have diarrhea, and it's not due to an infection. Instead, it's due to a factor H deficiency. And factor H typically degrades C3 convertase, which is responsible for activating the complement pathway. And so if you don't have factor H, you have unregulated complement activation. And what organ does that hurt first? The kidneys, because not only do they receive 25% of your blood supply in any given minute, but they also try to filter the blood. And so all that complement just smacks into the basement membrane and gets stuck and starts hurting the endothelial cells, the podocytes, the mesangial cells in the vicinity, and it gets inflammatory cells in there because complement, when you activate it, C5a is chemotactic for neutrophils. So there's your vascular damage. You peel back some of that endothelium, you start getting clots. That's going to lead to thrombotic microangiopathy, hence the thrombocytopenia. Then we're right at the end, renal infarcts. You know what a wedge-shaped infarct is. And now you know about as much about this SDL as I do. So thank you for listening.